Hello, everybody. We are going to get started with our afternoon sessions. The first session that we will be hosting to this afternoon is titled Transfusion Medicine in Sickle Cell Disease. We have two excellent speakers today, and the first speaker is Dr. Aditi Khandelwal. She currently works at Canadian Blood Services as a medical officer and a hematologist and transfusion specialist at St. Michael's Hospital and Sunnybrook Health Sciences in Toronto. Aditi completed her medical degree at McGill University and her postgraduate training in internal medicine, hematology, transfusion medicine, and a master's in systems leadership and innovation at the University of Toronto. She is a stem cell registrant, a blood donor, a blood prescriber, and a passionate advocate for improving blood use and availability, and a medical educator. Please help me extend a very warm welcome to Dr. Aditi.
Is my mic working? Yeah, it seems to be. Good afternoon, folks. I get the great pleasure of following lunch, so you're still stuck here with me. My name is Aditi. I will be moving around because I can't see the slides while I'm standing here. I wanted to speak about alloimmunization or red cell alloimmunization, and we'll be delving into some of the nitty-gritty details about why and how this happens, so we can understand how we can prevent red cell alloimmunization. I try to gear this talk towards anybody, so I'm hoping that I can at least put these concepts in a way that anybody can understand and you can take away something valuable from this talk today. So without further ado, as mentioned, I don't work at UHN. My affiliation is with University of Toronto, but I'm a transfusion specialist at St. Michael's Hospital and Sunnybrook Health Sciences. I am an apheresis doctor, so I do perform red cell exchanges, and oftentimes in moments of crisis rather than chronic outpatient exchanges. I did have some input from Dr. Matthew Yan, who's the leader of our rare cell registry here at Canadian Blood Services, and I'm hoping that we can all take something away from this talk today. So when we start talking about alloimmunization and the immune system, we have to start with recognizing and how the body recognizes ourselves. We are all unique. We have a genetic thumbprint that's unique. And what it encodes is important factors like the HLA proteins, as well as the proteins that are on top of our red cells. And the complement of these things are entirely unique to us. That's how our body knows who we are. And that's why this topic comes up when we start talking about stem cell donation and transplants, right? We're talking about HLA and red cell transfusions because we're talking about proteins that are on top of the red cell. When I talk about proteins and markers, I'll be using certain terms interchangeably. These in the biology stuff includes antigens. Antigens are the specific proteins or markers that our body is recognizing. And antibodies, which are the reaction of the body against these antigens when it's recognized it. So our body will recognize our own identity and know how that's different from anything that is different from us that we encounter, be it bugs, be it transfusions, which is coming from another individual. When our body recognizes something that doesn't look like us, we have a few ways of responding to it. So, recapping, what is inherited is our identity in those antigens. What changes constantly is how our body responds to what we're exposed to, because our environment is very different depending on where we are and what our exposures have been. Right? So it's very important to remember that there is an inherited portion to this piece and there is an environmental portion to this piece. And I'll show you how that becomes important in alloimmunization. One of the ways our body reacts is by making these antibodies. And these days we're all very familiar with that after vaccines, and our body mounting the antibody response. Similarly, against other antigens that we'll encounter. Red cell alloimmunization, big term, but very simply, a red cell has identity markers on there, antigens. Allo is anything pertaining to something that comes from another human being, another individual. And immunization is our response against that. So the antibody response to the red cell marker exposure from a donor is red cell alloimmunization. Every donor will have their own complement of antigens on the red cells, and our red cells have a large variety of proteins on there. They're not all created equal, meaning some of these antigens are going to be more challenging in terms of causing a recipient to identify them as foreign and cause a response compared to others. So I'll show you a little bit of that in a moment as well. The first time you're exposed to anything, and you will remember this from your experience with vaccines, it takes a few weeks for our body to mount this response. So it'll take our body's machinery about 2 to 3 weeks to make these antibodies. So that's the first exposure. But after that, our body's ready, right? Our physiology is trained for this. Next time our body's gonna see that same type of stimulus or antigen, our body's ready to go. And here's one tricky piece in sickle cell warriors and our patients who are living with sickle cell, who have antibodies. There is a sweet window of time when these antibodies can actually be identified, because 2/3 of these antibodies are gonna become quote unquote undetectable. Meaning, if we haven't captured this through a blood test done in 3 to 4 weeks, so about a month's time after exposure to the blood transfusion, 6 months on or a year on, we may not be able to see these antibodies, but they're there. And that's a unique challenge that clinicians like myself will encounter when we do a simple blood test to try and figure out, are there any antibodies? That blood test in one point in time is not enough. You need an entire history of every blood test that may have been done before and respect all of those antibodies. Because just because my test assays aren't good enough to detect them doesn't mean they won't do their job, right? So that's one of the challenges that we have when thinking about transfusion, and I'll highlight some of these other challenges as we come along the way. All right. So why does this topic of red cell alloimmunization come up, particularly when we talk about caring for people with sickle cell disease, right? Or if you are somebody who is receiving transfusions and you have sickle cell disease. This is why. So on the left side, I have a graph. It shows you what proportion of people who've received transfusion with a certain diagnosis will develop that antibody response. It is the highest in people living with sickle cell disease. Almost 1 in 2 people with sickle cell disease who will receive a transfusion will develop antibodies. There are 2 important pieces here. One is the fact that so many people will develop antibodies, so we have to be on top of it. We have to think about it, we have to test for it, we have to have a good way of communicating it. There is a second piece. Why do 1 in 2 people not develop antibodies? What's magical about 1 in 2? We actually don't entirely know. You can't predict upfront who's gonna be the person who gets these antibodies and who doesn't. You have to be vigilant. So you have to assume that anybody being exposed to a blood transfusion will develop antibodies, okay? Because currently, we cannot predict. There are certain clues that we have to be more vigilant in certain situations, and I'll go over them in a moment. Whether somebody is going to develop antibodies is dependent on many different factors. One is the recipient themselves. Are they having an exposure to a blood transfusion? How many? How frequently? In what situation? When they do get it, what is their immune system doing? The blood cells themselves, what are the antigens and markers on top of these cells? And there's one other critical piece to this. Do we know what markers are on these donor cells? Because there's one thing about having these markers, and the second thing about medical science being able to tell you reliably what these markers are. Testing for markers on the red cells in our donors, as well as our people with sickle cell disease, must be done in a proper way because we can miss certain markers. And some of the markers that our testing technology can miss today are actually the most important ones that we need to worry about. And I'll show you a few of those. All right, so let's start firstly by thinking about these markers and the important mismatch between what markers are on the donor cells versus what are on the recipients, and what the recipients or the person receiving the red cells will recognize as their own versus not. When we perform a transfusion, we have to think about it in terms of doing a transplant. You're trying to evade somebody's immune system and give them something from somebody else. And I think in a day-to-day clinical setting in a hospital, we kind of dismiss how significant that is. This is a critical piece of information, and it's not taken as seriously as it should be. Okay? There are a few different issues here. Firstly, who are our donors and who are our recipients? In Canada today, amongst our blood cell donors, 0.8% of our blood donors are from African, Caribbean, and Black descent. 3.2% of the Canadian population belongs to that ethnicity. There is a major mismatch. Right? This mismatch I'll show you how it can be advantageous and disadvantageous depending on the situation. So secondly, recipients are people living with sickle cell disease. People with sickle cell disease have sickle cell disease as something that's an inherited illness because it was selected for, because sickle cell trait gives humans a superpower, and that is to survive malaria. It is actually an advantage for the human race for that sickle cell trait to be inherited. That's why we see sickle cell disease in populations where there is more malaria because of the selection pressures, because people can survive longer to be able to have children, right? So it's actually a superpower. It only becomes a challenge when you try to circumvent that through something like transfusion, because our human brains, when we're trying to do this, and our medical technology isn't as good as nature. So people living with sickle cell disease are more likely to have less common antigens that look different from our donor base. Okay? This is what allowed their ancestors to survive. Okay. Thirdly, there is one particular blood group that we specifically worry about a bit more. It's the Rh, and amongst the Rh blood group, it's the D. So when I talk about Rh, people have heard of blood groups being like A pos, B neg. So when we're saying pos or neg, we're talking about the Rh. Okay? The Rh blood group has the most amount of variability in there, and that's where the genotyping assays of today fail the most. And the Rh blood group is the one that is the most diverse amongst people of African, Caribbean, Black, as well as Middle Eastern, Asian, South Asian descent. Okay. So there actually have been studies in places outside of various countries in Africa, like North America, where there was an attempt to match not just the markers that we know, but also with ethnicity. So there's a paper published by Dr. Stella Chow, who's a great academic in this field. And there was an interesting conundrum that arose. And it shows you the failure of technology today. So people who received ethnicity-matched blood as well as antigen-matched blood actually had a higher chance of developing antibodies against Rh, specifically Rhd. Why is that? It's because our serology assays, so phenotyping and genotyping, the different ways we try to figure out what's on the red cells, isn't that great, especially genotyping. It also fails at identifying certain variants in the D. And that's why we saw that signal. And until we have better assays widely available for D, this can be a challenge. So when I say the ethnicity may not match between donor and recipient, and it's a kind of a two-edged sword, the trick there is the D. You're more likely to find D negative blood from the 87% of our Caucasian or white donors. You're more likely to find D positive blood from our ACB communities, but that D pos, our genotyping assays can fail us there. Is that a real regular D, or what kind of D it is? That's the piece we fail at, and we need to do better. And that's where next generation sequencing comes in. Okay. I think I spoke to this already. So if there is a difference between donors and recipients, is alloimmunization rate lower in countries in Africa? So there's a systematic review that was done. And in this systematic review, 15 studies were looked at. And the meta-analysis did show that the alloimmunization rate is slightly lower when you are in a country where the donor and the recipient population ethnicity matches. So there are gains to be made. Each one of us can contribute to decreasing alloimmunization. What is the challenge in this study? The assays that we use here today for phenotyping and genotyping and the frequency of testing to identify the antibodies wasn't actually done as frequently in many of these studies. And when it was, the alloimmunization rate was only about 5% different in that graph that I showed you earlier. But we will take that 5% because it can make a difference in our patients' lives. Okay? There's large variability in that data. Okay, so just having one exposure is not enough. What happens when somebody encounters somebody else's blood again and again and again and again? Dose matters. So the risk of developing alloantibodies increases until about 40 unit exposures. This is where you start seeing a difference between people who are on a regular transfusion strategy, chronic outpatient exchanges, versus acute exchanges once in a while. Okay? Not only does the number of exposures matter, it also matters in what situation they were given, at what age, and at what frequency. So if somebody is receiving a blood transfusion above the age of 5, they're more likely to form antibodies. Also, if the transfusion happens episodically, meaning it's a rescue transfusion, meaning this is a situation somebody's had a stroke, or somebody's had acute chest syndrome, and this is a transfusion that is being done acutely, that transfusion is higher risk transfusion for alloimmunization than the regular outpatient transfusions. And that has to do with how our immune system is primed to be vigilant for something going on when we're sick. Okay? So the episodic transfusions are to be very wary of. And this is a problem. Because when do people go to a center that is closest to them? When they fall ill and something's happened all of a sudden. But that center may not be your usual center. That center may not have your transfusion history, right? And that's where our mistakes happen in terms of not getting the right blood prescribed. And this is exactly why we need to work really hard in making sure that all of that transfusion history is visible no matter where you are. Because you can't drive down to UHN if you're elsewhere and that happens to be your center, you know. And that is a challenge that we're contending with currently. We can talk a bit more about it in Q&A. So So what happens if somebody has these antibodies? These antibodies will attack the red cells and cause hemolysis. This is called delayed hemolysis. And then there is a very scary complication called hyperhemolysis that you may be aware of. Hyperhemolysis has a fairly high risk of somebody not making it through that. Okay, and that's what we're always scared of as clinicians. Is we have to be vigilant. We need to prevent this complication. In people receiving episodic transfusions in this one study from France, where they have 312 sickle cell patients in the study, the people in the episodic arm are the ones who were exposed to this risk of delayed hemolysis. And the reason being, perhaps this was happening in centers people are not known at, perhaps where their antibody history is not known, and their immune system's ready, to fight whatever's going to happen next. Because that's what our immune system's supposed to do. Okay. That's where we get into the priming of the immune system. So just briefly, if somebody has acute chest syndrome and they're going to be receiving a blood transfusion in that context, their odds ratio of having alloimmunization is 13.2 compared to another person who might be there with a risk of 1 considered as baseline, okay? So this is a much higher risk of alloimmunization. And in that context, if somebody called me and I'm at CBS and they're like, I want to match for every single antigen that I can potentially match for, no argument. That is exactly where we're going to use the most extensive matching that we can, okay? I alluded to the fact that not every antigen is made the same. Our body is going to respond to certain proteins much more, aggressively than other proteins. Some of them are more of a danger signal than others. And RHD comes back here again. RHD is the highest danger risk in terms of antigens. So we have to do better at recognizing all of the D variants. Amongst the other various antigens that we have, the Kel antigen and the big E are the next big alphabets that you need to worry about, and that's why every single transfusion for anybody with sickle cell has to be matched for Kel and big E as well as C. Okay, so those are the antigens that we're definitely going for upfront. All right. So where can we make a difference? So when it comes to our potential donor factors, we need to decrease the discrepancies between our donor base and our recipient base. Right? That is definitely a place where we have a lot of room for improvement. In terms of the actual antigens, we need next generation sequencing. We need better ways of identifying the D variants, because they're the ones causing most of the alloimmunization risk in our patients. In terms of our recipients, in people living with sickle cell disease, we need to do better at getting that information about them when they need it, where they need it. They need to have best testing available. They need to have their healthcare history available so people can make smarter decisions. And also, clinicians making these decisions need to know that these factors are important. So there is a bit of a gap. And I'm sure that has been a major theme in our 2 days here. Go through this.